Good morning, ladies and gentlemen. Welcome to the first morning session of the, the last day of our annual sessions this year. This is a teaching capsule which we are having now, and I'm very pleased to have here someone that we invited specifically for this particular purpose and this topic, Dr. Prashantha Jayasekara, who is at the moment the consultant physician at the teaching hospital Karapitiya, but we all know that he has played a pivotal role in the field of emergency medicine in Sri Lanka. So he is a very good authority to talk about this, if not the best authority. He's going to talk to us about fluid balance, the basics and the advanced. And that's a very important topic for frontline healthcare workers, especially our postgraduate trainees. So I welcome you, Prashantha, for coming early morning and joining us today, as well as our audience from online. Can I ask Prashantha to take over and then to tell us about the fluid management? Thank you.
Thank you very much, Chairperson, sir, for the kind words of introduction. So my topic today is going to be fluid balance, basics and advanced, and judicial fluid administration to critically ill patients. Let me start with the case scenario of a 54-year-old hypertensive male admitted with 4 days history of headache, body aches, nausea, and poor oral intake. On admission, he has signs of mild dehydration, afebrile. He has a pulse of 98. His blood pressure is 110/75, though he is an hypertensive. Rest of the examination was normal, and he weighed 60 kilos. Now, he had his routine blood test done on admission, and the admitting doctor's first question whether this patient should deserve intravenous fluids. Next question would be, what is the fluid, what rate, and what volume? Third, the question later on would be, after 24 hours, whether this patient would need further intravenous fluids. So I think before, the first thing that we decide is whether our patient needs intravenous fluids. This decision has to be justified. And we know deciding on the type of fluid, the volume, and the rate is always going to be difficult. And added to this assessment is done by the junior most doctor and is being administered by the nursing officers. So there is evidence to suggest that there is mismanagement, which can lead to increased morbidity, mortality, prolonged health hospital stay, and cost of health economics. Now, there are principles involved in fluid prescribing that I will elaborate first. So before we prescribe fluids, we need to know 4 things. 1, the physiology of fluid balance in health. So what is the fluid and electrolyte balance under physiological status? Number 2, the pathophysiological effects of fluid balance. Number 3, clinical approaches to assessing IV fluid needs. Number 4, the properties of available IV fluid. So we need to we'll take one each and we'll discuss the physiology of fluid in health. 60% of a male's body weight is fluid, and it's 55% in a female. So out of this 60%, 2/3 is intracellular, and is only 1/3 is extracellular. So out of this extracellular volume also is only 20% that is intravascular. So we would be administering fluids intravascularly, but that fluid has to actually balance the intracellular and interstitial compartments as well. Now, fluids go hand in hand with electrolytes, and now there are cations and anions which are in equilibrium. The major cation in extracellular fluid is sodium, whereas it's potassium in intracellular. If you consider the anions, chlorides are the major anion in extracellular, and phosphate and proteins would be the anions in intracellular. So these you need to know, because these can get disturbed with disease state. Now this I have just summarized the 4 major electrolytes, 3 major electrolytes. The sodium is mainly extracellular, whereas potassium is mostly intracellular, and chloride is also mainly extracellular. Now, second thing we need to know, now that is the physiological aspects of fluid and electrolyte balance and what happens in disease. Now, changes in fluid and electrolyte handling will change with disease, especially when there is non-specific metabolic stress secondary to disease. Other thing is directly attributable to specific organ dysfunctions. For instance, if you have a renal dysfunction, the patient will definitely have fluid electrolyte imbalance due to disordered handling. And then there is due to restricted input secondary to critical illness also will influence the fluid balance. So these are the pathological process that can influence due to disease. Next thing is to see the clinical approach of assessing whether my patient really need intravenous fluids. So first thing is does my patient need intravenous fluid resuscitation? If the patient is in a decompensated shock, this patient would need fluid bolus. And if not, can my patient take orally? And if not, the patient should be given intravenous fluids. Then if you decide to give intravenous fluid, what's my patient's current daily requirement of fluid and electrolytes? Now, next thing, does my patient have existing fluid and electrolyte disturbances to start with? Finally, does my patient have any other comorbidities that would influence my fluid administration? So this is how you assess the fluid needs of a patient. Now, final thing that we need to know are the properties of various fluids. So we have isotonic saline, which is called as normal saline. We have balanced crystalloids comprising of plasmalite and Ringer's lactate. We have glucose and glucose dextrose saline solutions. We have synthetic colloids, which are either gelatins or starches, and then we have albumin. So these are the 3 crystalloids and 2 classes of colloids that we use commonly in practice. So just to see the composition, if you, now this is on your left, you have the crystalloid composition, and on your right, you have the colloid composition. So if you compare with plasma, the isotonic saline sodium concentration is slightly higher than plasma. And the most worrying thing is the chloride concentration is 1.5 times that of plasma. So if you, when you give, so you have to be a little mindful about the amount of chloride that you are giving with isotonic saline. Then if this is true for colloids as well, some of the colloid solutions will contain more chloride, and some will have more sodium. So you have to be mindful about the composition of each and every fluid that you are using. Now, next thing, once you have decided on these 4 factors, then you need to know which category your patient falls into. Whether your patient needs resuscitation, whether your patient needs only routine maintenance, whether your patient needs to replacement of ongoing losses. For somebody who's got diarrhea or vomiting, it's only the ongoing losses that we need to replace with the maintenance. Or whether you've got some redistribution problems. For instance, somebody who's got liver disease, renal disease with gross edema, or somebody who's septic, who is losing fluid into the interstitial space. So these are the 4 classes of patients that we encounter. Now, the most important thing, after each and every fluid administration, we need to reassess the patient, whether the patient still is in the maintenance group, whether the patient, if somebody's got resuscitated, whether the patient is fully resuscitated, If so, what is his next level? Is it a replacement that he needs? So reassessment makes it 5 hours. So these are the 5 hours which are very important in deciding the initial fluid administration. Now we will go back to the same case scenario, which is a hypertensive patient who has gone off feed, is mildly dehydrated, is tachycardic, and is otherwise stable hemodynamics. So this patient, we need to decide whether this patient needs intravenous fluid. If so, what is the fluid and what rate and duration? And then how would you assess further fluid needs? So this patient falls into the category of routine maintenance because this patient was otherwise well with good hemodynamics. He had been off feed and is mildly dehydrated. So this patient needs routine maintenance. So next we need to decide whether this routine maintenance can be given oral. It seems that patient had been unwell, had not been taking orally, so he should need intravenous fluids. Now, these patients are otherwise well, and then you need to have the patient's routine maintenance requirements of fluids and electrolytes. Before administering fluid, you need to always also think that whether this patient has any comorbidities as well. Now, so we decided to administer intravenous fluids, and the recommended volume is 25 to 30 ml per kg per day of water, and 1 to 2 ml per kg per hour rate, and 1 millimole per kg per hour of sodium, potassium, and chloride. Then to prevent starvation ketosis, we need to give 50 to 100 grams of dextrose if the patient is not taking any carbohydrates orally. And for patients who are obese, we need to take their ideal body weight rather than the actual weight. And then you need to consider other comorbidities. For especially somebody's got cardiac or renal disease, we might reduce the total volume to 20 to 25 ml per kg per hour. So this is a recommended routine administration which we will imply onto our patient. So my patient is 60 kilos. He will need about 1,500 to 1,800 ml of fluid. Electrolytes about 60 millimoles each, and 50 to 100 grams of glucose. So presume you decide to give 2 pints of normal saline coming into 1 liter and 2 pints of 5% dextrose. So you see, you are giving a little too much of sodium and chloride. If the patient's physiological systems can handle, that should be okay. But if there is this in a disease state, this definitely might cause some trouble because you might cause a little bit of hyperchloremic acidosis. So you have to be mindful about the composition of each and every fluid that you are giving. Now he said 2 liters of intravenous fluids, and he is better, hemodynamically stable. His hydration seems to be normal, and now he is able to take few sips orally. So next decision, whether you need to continue fluids on this guy. So, and if so, what type and volume rate. So this is where we come into the next level, that is next R, that is a reassessment of further fluid. So for this, first thing is a history, clinical history, to see whether the patient just is feeling better, and then examination of vitals, pulse rate, blood pressure, capillary fill time. Then measurement of urine output and fluid balance chart is very important, whether the patient has had adequate urine output from to the volume that you have given. And also you need to make account of the insensible losses. These losses are going to be high, especially if a patient is febrile, they will lose more sweat and other insensible losses. So you need to make account of these as well. Now, body weight measurement is also important, especially in obese edematous patient. So after history examination and the bedside measurements, you need to do urea and electrolyte test to see how the electrolyte composition is, to make sure that you haven't given too much of sodium, too much of chloride, as I have described you, because which can cause a hyperchloremic acidosis. The chloride assessment is quite important. Now, once you have assessed the history examination and basic investigation, you can decide if this patient seems to have recovered, so we can go back to his oral maintenance with nutrition. So you replace nutrition, fluid and electrolytes orally. So this is how we manage a patient who admits otherwise well, who needs routine replacement only. Now we go to the second case scenario of a 54-year-old lady with poorly controlled diabetes and hypertension, was admitted with 3-day history of dysuria, fever with chills and right loin pain, altered level of consciousness for 1 day. On admission, this lady is febrile, tachycardic, hypotensive, tachypneic with normal saturation, GCS is 13, capillary blood sugar is high, there is metabolic acidosis, there is lactic acidosis, urine ketones are negative, and this patient comes with a few basic reports with neutrophil leukocytosis, very high CRP, and high creatinine. So these are the cases that we come across in day-to-day practice. So these are the problems that we have identified. And now next thing is, what is your fluid management? So which category does this patient fall into? This patient should definitely need resuscitation. So next, now who are the patients who would need resuscitative fluid on admission? If your patient fulfills 2 or more of the following, that will likely to indicate resuscitation. So pulse rate of more than 20, systolic blood pressure 20 millimeters below the baseline, capillary refill time greater than 2 seconds, respiratory rate more than 20, urine output less than 0.3 ml per kg per hour. So if you, in addition, if you have lactic acidosis, these all will support that this patient would need resuscitation. So my patient definitely would need fluid resuscitation on admission. So next thing, if you decide on a fluid administration, what is the type of fluid? Would you need to give a crystalloid or colloid? If you decide to give a crystalloid, is it a balanced crystalloid or is it isotonic saline? If you decide to give a colloid, it's a gelatin, starch, or albumin. And what is the volume? Usually what you do is you give 10 ml per kg bolus. You can repeat it to thrice, that is coming up to 30 ml per kg of bolus. Then rate, whether it's fast or control rate, the duration, early or late. So we'll go to the scientific evidence. Now, first thing, this is a Cochrane review of colloids versus crystalloid for initial fluid resuscitation. There were 4 arms. One is crystalloids versus starches. Second one, crystalloid versus dextran. Third one, crystalloids versus albumin. Then we have crystalloids versus gelatin. So there are 4 arms, and they assess the final out or mortality or morbidity. So the conclusion was that crystalloids are superior to colloids, especially synthetic colloids, because synthetic colloids tend to cause more renal damage, and these patients ended up in renal replacement therapy. So but there is a subcategory of patients with severe sepsis who had equal response to albumin as well. So then we decide, what we concluded was crystalloids are superior to colloids. Now next thing, is it isotonic saline or is it balanced crystalloids, which is better? So this was again, this was a study that was published in 2018, which is known as Smart Med study or Smart Surge study. And this basically assess isotonic saline versus plasmalite or Hartmann's, and it concluded that the balanced solutions are superior to isotonic saline because balanced solutions tend to cause less renal damage. So now we know, now these are the conclusions of fluid resuscitation. Use crystalloids with composition close to plasma, that is balanced crystalloids over colloids, and do not use starch or gelatin for fluid resuscitation. Consider 5% human albumin solution for fluid resuscitation only in the category of severe sepsis. So this was the conclusion on fluid resuscitation, the type. And then once you have resuscitated your patient, then you need to reassess the patient. So this is a fifth R, to see whether your patient has come out of the decompensated shock. But if the patient is still in compensated shock, patient would need further replacement. It's not with fluid boluses. If the patient has no ongoing losses, the patient can be put back onto routine maintenance. So this is the decision that you need to make after your initial fluid resuscitation. And once the patient is stable, you can go back to oral or enteral maintenance. Now, traditionally, the fluid resuscitation is divided into 4 stages: the rescue phase, the optimization phase, stabilization phase, evacuation or descalation. This is known as ROS or ROS-D. So rescue phase, now these are the 4 stages, and rescue phase is for when the patient is in a decompensated shock. We give a fluid bolus, preferably a crystalloid, and we reassess the patient. Now this is our patient back again. Patient had 2 10 ml per kg crystalloid boluses of balanced solution, and 3 hours later patient was clinically improving. But still the patient is tachycardic. Now she's comphysimentous. Now what is your fluid management? So this patient, which phase of is she right now? She's now in optimization phase. So this is the stage where you replace the ongoing losses. This patient is septic, so probably there is fluid sequestrating into the interstitial space. So you need to reassess and give some fluid challenges. So now we have given a fluid bolus, next fluid challenge. So what is the difference between a fluid bolus and a challenge? Fluid bolus is what we give a 10 ml over 15 minutes. Fluid challenge is something little different. You give about 100 to 200 ml over 5 to 10 minutes and reassess the patient. So that is what we usually do. Now, this is the concept of TROL involved in fluid boluses: the type of fluid, the rate, objective, and limits. So type is usually crystalloid. The rate is 100 to 200 ml over 5 to 10 minutes. The objective is to improve microcirculation, and the limits are to make sure that we don't overload, that is to look at the CVP and other parameters as well. So this is what is TROL in fluid challenge. So after 24 hours, the patient has normal hemodynamics. So we have given a couple of fluid challenges. The patient has improved now. And when you calculated the previous 24-hour fluid intake, it was 2,400, but the output had been only 800 ml. Creatinine has creeped up a little. Now, what is your next recommended fluid administration? And so this station is in stabilization phase. Now this is the routine maintenance. So we need to just administer the routine maintenance, either intravenous or combination of intravenous plus oral. The target should be to 0 or slightly negative fluid balance. Now, once you have done this, we have the next stage, that is the evacuation or de-escalation. This is the phase where where the purpose of this phase is to remove the fluid that had been extravasated. So this usually happens spontaneously. They will spontaneously go into diuretic phase. If not, at this phase, we can consider giving some furosemide. So be mindful. We usually shouldn't give fluids in the other 3 stages of illness. It's only the de-escalation phase only that we give some. When we are sure that the patient is in de-escalation phase only, we give some diuretics. So if the patient's spontaneous or pharmacology are not helping, you might need to go for a renal replacement therapy. So in summary, so this is the fluid resuscitation in critically ill patient. You have the rescue phase, you have the optimization phase, stabilization phase, and de-escalation phase. Reassessment is very important. Sometimes the patient still in the rescue phase, so give another fluid bolus. Reassessment in the optimization phase, if the urine output is low, hemodynamics stable, still ongoing fluid loss to third space, give fluid challenge. Then stabilization phase, continue maintenance, and de-escalation phase, cut down on fluid and see whether the patient is going into spontaneous diuretic phase. Now we will move on to the third case. It's a 54-year-old known patient with child B cirrhosis and diabetes, presents with low-grade fever, abdominal pain, loose stools, altered level of consciousness, and poor oral intake. So this is again a very common scenario that we come across. This looks a little complex though. On examination, he weighs 84 kilograms. He's icteric. There is generalized edema. His pulse is 78, blood pressure 110/70. His GCS is 14, and he's got moderate ascites. So the picture is further complicated because he's got a neutrophil leukocytosis, he's thrombocytopenic, his CRP is high, his creatinine is high, urea is also elevated in parallel, he's hyponatremic with moderate edema, his albumin is also low. So this is basically a complex patient with disordered physiology needing fluids. So what is your fluid management? So does this patient need resuscitation? Obviously not, because the patient's hemodynamics are stable. Does this patient warrant routine replacement? I don't think that will only help him because he doesn't look that well with his comorbidities. Now we are left with the replacement and redistribution categories of patients for initial fluid management. So now you just, if you list out the problems, you have a child B chronic liver cell disease patient who's got the fever, who's got diarrhea, there is altered level of consciousness, and then there is generalized edema, jaundice with ascites. He's got hyponatremia, there is probably acute kidney injury, then there is anemia with low platelets, maybe part of the disease process itself, and then this patient has got low albumin. So if you consider the second principle, the altered physiologies of, so you can find many alterations of his normal fluid and electrolyte status. So this might make the decision making little complicated. So the first question, would you start IV fluids? I suppose yes. What type? Whether it's a crystalloid or colloid or combination. So this patient has got moderate ascites, generalized edema, hyponatremic, and probably there is ongoing infection. So is it crystalloid or is it colloid or is it a combination of crystalloid colloid? And if so, what rate? Can we give 1 ml per kg per hour, or can we give 2 ml per kg hour? So this looks a little complicated case scenario where you should administer fluids. So intravenous fluid therapy in replacement and redistribution is not always easy, and you have to do it quite meticulously as well. Now, replacement of ongoing losses. So this patient has ongoing diarrhea. So this patient's, but the patient is hemodynamically stable, does not need urgent resuscitation. And then you need to assess the patient's ongoing losses and also the existing fluid and electrolyte disturbances. So for instance, this patient is hyponatremic, but this obviously is a chronic hyponatremia with volume overload. So there's a hypovolemic hyponatremia, you might not correct it. Then what is redistribution? Redistribution is a concept where patients who got either fluid electrolyte handling problem or disease process causing sequestration for something like sepsis, or somebody who's got major cardiac, liver, or renal comorbidity. Now, this patient definitely has got a major liver comorbidity. So this patient has a redistribution problem. So we have to be mindful. So this is a case where the patient has both replacement and redistribution problems. So how would you tackle this sort of a difficult situation? So existing fluid or electrolyte deficits should first be addressed. Then you need to address the ongoing abnormal losses. So this patient has got diarrhea, so you need to make account of the volume that is lost with diarrhea. Then what are the redistribution problems? This patient has got liver disease. Probably this patient has got some sepsis, maybe spontaneous bacterial peritonitis. So patient is losing fluid into interstitial phase and is already got moderate ascites and he's got generalized edema. So making account of these problems, so you decide what type of fluid, what rate that you administer. So you need to calculate the ideal body weight, though is 84 kilograms, is generalized, there's generalized edema. Then you check the fluid status. Obviously, this patient is hypervolemic. Calculate the daily requirement of fluid and electrolytes, and keeping in mind that the patient already has got some electrolyte disturbances. And take account of ongoing losses. This patient's got diarrhea. So then meticulous input-output chart is very important on deciding, and also reassessment, and then their weight, daily weight assessment as well. So these are the factors that will decide whether my patient would need intravenous fluids. If so, is it crystalloid? If is it colloid? Is it a balanced crystalloid? Or this patient needs a combination of crystalloids and colloids. So, so I would say this patient would need a combination of crystalloids and colloids, and because this patient is maintenance crystalloids at a 1 ml per kg per hour, then colloids, because this patient has got edema and hypoalbuminemia, some 5% albumin, and then of course after maybe 12 hours or so, the patient needs to be reassessed on the electrolyte status, the output, the weight. So then you need to reassess and go back to either daily maintenance, or the patient, we need to consider further replacement of losses or replacing the redistributed volume. So this third case scenario is quite complex, but just to highlight you on the complexities that you face when fluid is administered. So ladies and gentlemen, in conclusion, understanding the basics of fluid and electrolyte balance in patients with normal physiology and during illness is very important in deciding the type of fluid, the volume, and rate that we administer. And we need to know the compositions of fluids, either crystalloids or colloids, that we administer, because some of these are either they contain more electrolytes or less electrolytes, or they are hypertonic. So you need to be a little mindful of those factors before you administer any type of fluid. You need to assess before you decide on giving intravenous fluid, you assess the risk, benefit, and harms of intravenous fluid therapy, as I have stressed you, because sometimes these are done at a very low level, in the sense at the primary level. So you need to be a little mindful of the complexities involved in certain patients. Remember the 5 R's: resuscitation for patients who are in shock, routine maintenance who are stable but not able to take orally, replacement for patients who are having ongoing losses, redistribution for patients who have got third space fluid sequestration, And of course, then the reassessment in each and every phase would need reassessment before you embark on further fluids. And finally, ensure medical and nursing staff who prescribe and administer fluids are mindful and aware of the basic physiology and pathological processes involved with fluid administration. Thank you.
Thank you very much, Prashant, for taking us through the fundamentals of fluid management. Can I ask you to come and take your seat? We can enjoy some questions while we wait. So let me remind you, you can type in your questions to the Q&A facility that you see in your screen. So do type in your questions while we have a conversation between the two of us about fluid management. Now, Krishanta, let me just take you through your talk from the beginning. And you quite rightly started off by revisiting the physiology of fluids. That's very important for us to know. You mentioned a very interesting concept called insensible loss. Can you describe to us what exactly that means to us?
Yeah, actually, so now there is a lot of fluid. Now we presume this is around maybe about 10 to 15 ml per kg for 24 hours of fluid, which is lost through sweat and other means of insensible losses. So this, the important factor is we tend to ignore this in our fluid balance chart. And also certain disease processes, as I have mentioned to you before, during the high spiking temperatures, they lose more fluid through insensible losses. So we need to be mindful of that as well. So this is actually been ignored and not counted in our daily fluid balance charts. So which is obviously important when you want to replace their lost fluid.
So it's about 10 to 20 ml per kilogram per 24 hours.
That's right, yeah.
So I suppose...
10 to, yeah, that's right, yeah.
Okay. I mean, what are the situations where the insensible loss can be altered? You mentioned one of them, the high temperature presumably makes it an increased insensible loss. What about other situations in clinical practice?
Yeah, other things like, you know, even for certain, sometimes the other thing is even a diarrheal illness can cause a little bit of a significant fluid loss, which can be ignored unless you make account of the amount of fluid that is lost to diarrhea. So there are other processes that could lead to increase in insensible losses.
What about when the patient is in an ICU, which is an air-conditioned environment? Do you have a change in the insensible loss?
Definitely, yes, because your insensible losses might alter with the temperatures in the intensive care units.
Okay, right. And I mean, obviously, in the case of the surgical patients, like burns patients also.
Definitely, yes. Yes, of course. So we have a little bit of, yeah, that's right. Yeah.
Yeah. So of course, in medical cases, fortunately, we don't have that complexity, but occasionally you come across burnt patients as well that we have to look after, and also bullous disorders, isn't it? I mean,
yeah, certainly, yes. Dermatological disorders with some bullous disorder where they have discoloration of skin, so they lose a lot of fluids through their skin lesions.
That's right. Yeah. Thank you. Well, you also brought out the important point that there are other avenues of fluid loss which can be exaggerated in disease states, and you gave the example of diarrhea. It can be vomiting, it can be our intercostal tubes or drainage tubes and things like that. So let's say if I'm a house officer and I have a patient who has some of these pathological states of diarrhea or vomiting and so on. If it's a tube, of course, we can measure the output very easily from the tube, like a surgical tube. But in a patient with diarrhea or vomiting, how do I calculate the additional losses and add to the fluid balance?
It's not going to be that easy though. So you, maybe that you make account of the, you know, the episodes or frequencies of each and every, and then calculate maybe 100, 150 mLs of fluid per each, depending on the amount of diarrhea. So some people have profuse diarrhea, so you need to, it might be around, maybe around 10 ml per kg. So likewise, so you need, it depends on the individual patient. So we need to individualize these situations.
Okay. So it might be a good idea to add about 100 ml or 150 for one bout of vomiting or one bout of diarrhea. But if it's a profuse diarrhea, you might have increased to 200, 250, 300 per bout as well. We have one question here, which is asking us to go back to insensible losses. How do you calculate insensible loss according to body temperature? I mean, I think what the questioner wanted to know is if there's a formula. I don't know if there's a formula that might be helpful.
That's right. So we usually have a 10 ml per kg for to 20 ml in a under physiological status for 24 hours.
Right. Okay. And then we have to just look at the environmental factors and decide
That's
whether
right,
to give more or less than that. Okay. So that's about insensible loss and calculating that fluid balance, and then trying to figure out where exactly our patient is in terms of fluid balance, isn't it? Let me take you to the first case scenario which you presented, that hypertensive elderly gentleman who came with a normal blood pressure for a healthy person, and where we were not too worried because he didn't need resuscitation because he was dynamically fairly stable. Now, one question that we always worry about is, what if this patient's usual blood pressure is not this and much higher? Maybe he is not compliant, maybe he is actually having uncontrolled high blood pressure, and now here he is with a BP which is okay for you and me, but for him it may be not quite the case. So that dilemma comes into our minds when we are in the front line. So how do you solve this dilemma?
Yeah, that's right. So, but I do agree, because his 110/70 might not be his normal, because he is a patient who is on antihypertensives. But of course, when you make account of the other vitals, his is not tachycardic. So the decision is whether you need to resuscitate this patient. But obviously, this patient does not need resuscitation. Then just to see whether this patient has any ongoing losses, that is not the case. So then this patient falls into category of routine maintenance, and we can always, but only the most important thing is reassessment. So we just can't leave the patient with fluids and review him after 24 hours, reassess him. So that is a role actually, if the house officers have to reassess the fluid maybe after 6 hours, whether the patient is still in the routine maintenance phase or the patient needs resuscitation, and then you change accordingly.
That's right. I mean, we can never answer all the questions on presentation. We have to just, okay, my plan for the next 6 hours is this, and then see what happens. And you made the very important point. Don't worry about the blood pressure, hypertension patient. Just look at the resuscitation criteria, because a normotensive person will develop that if he becomes hypertensive or hypovolemic. Similarly, the hypertensive patient who is used to the usual blood pressure will also develop those criteria for resuscitation if there's a hypovolemia. So we can still trust the resuscitation criteria that you mentioned, and that will guide us whether this so-called hypertensive is actually having a problem or not having a problem. That's great. We've got a few more questions. I'm going to stick with the hypertensive case, but this is a little beyond the case that you presented, because your patient was quite okay, the case scenario number 1. But we have a question, how do you calculate fluids in hypertensive emergencies? Is there any special rules that you have to keep in mind?
Yeah, it all depends on the hypertensive emergency that you are dealing with. Presume you have a cardiogenic pulmonary edema. You might need to, you want to de-escalate the fluid management. So basically, for others, I suppose fluid should be on a maintenance basis, but you need to be mindful about the sodium load that you are giving as well, because these patients are always hypertensive. So just stick to basic maintenance of fluid and electrolytes, but your main aim is to get down the blood pressure as soon as possible intravenously. But special attention is on patients who are with hypertensive emergency with cardiogenic pulmonary edema or hypertensive emergency with acute renal failure. You have to restrict fluids.
Right. So sodium is the enemy, if I can put that way. Always be careful about how much sodium we are giving our patient in that situation. Okay, there's another question. I think this is probably better for the second scenario now, that lady who came with need for resuscitation and also sepsis. And I think she had a bit of a slightly high creatinine as well, isn't it?
That's right.
Yeah. Okay. So there's a question, how do we assess the level of dehydration clinically?
quite important.
Yeah.
So we actually, there are clinical parameters that we can, one thing is vital. So we look at their skin, we look at their tongue, that is the basic thing. We look at their jugular venous pressure, but more so with the vitals. So the patient's vitals, if there is tachycardia, if there is hypotension, prolonged capillary fill time, if you have a lactate level, so these all will show that the patient has got tissue level hypoperfusion, and that indirectly indicates, and reduction in urine output, these all indirectly indicates that patient is dehydrated. And obviously now there is an important tool that we use in practice now, because we have the bedside ultrasounds. So we use it very often to look at the fluid status very easily. If somebody learns this technique of bedside ultrasound, to see the monitor the intravenous IVC, inferior vena cava, and see the diameter, and then you can guide your fluid replacement with the IVC diameter.
Great. So in the initial stages, the patient will probably feel thirsty, and then the so-called 4 windows come into the picture. The blood pressure and pulse rate can undergo changes with hemodynamics changes. The kidneys can become oligemic, and then the output can drop. And of course, you mentioned the CRT, which have become very sensitive about after dengue epidemics. That's a very useful measure. And finally, level of consciousness also as they go towards shock. So in the early stages, the dehydration, I think it will start off with thirsty, being thirsty. So we can use these parameters to get an idea about the blood volume or the plasma volume. Interesting thing, I mean, the definition of dehydration, correct me if I'm wrong, Prashant, it's actually a reduction in the ECF, am I right?
I'm not very sure.
Volume, from what I understand or remember, dehydration really applies to the extracellular fluid compartment. So basically, of course, we can't just replace the plasma volume compartment, because it is in sort of intimate contact with the interstitial fluid compartment.
Justified, isn't it? That's right.
Yeah, that's right. So we are talking about the ECF in that situation. One thing that sort of crossed my mind when we were discussing the second case scenario is we are probably going to have to give some intravenous antibiotics to that lady. And that also comes with its own volume, isn't it? Now, sometimes we have,
Yeah, that's right. Yeah, I think we have the first hour bundle in sepsis. So intravenous fluid administration within first hour is one of the cornerstones of management of sepsis, actually, that is out of our scope, but what we considered here was fluid administration. Yeah, definitely, yes. Thank you very much. Yeah.
Because sometimes these are infusions with a significant amount of fluids.
That's right. Yeah. So like
meropenem and so on. Yeah. Okay. Let me see if I have got any more. We had a few more questions. Yeah, I think we can move on to the third case, the very complex case about the patient with the gentleman with cirrhosis and ascites and hyponatremia, hypoalbuminemia, and then coming with what looks like a very low-grade sepsis himself, again with high creatinine and so on. So there's a question. In your third case scenario, would you give albumin? And I think you said yes, because you're going to get a combination of colloids and crystalloids. If so, what percentage? So I think...
unfortunately, we don't have the 5% albumin, which is the recommended intravenous. So we have the concentrated albumin in our practice. For the ideal would be to give 5% albumin.
So what do we do with what we have? Or do we give anything or not?
Yeah, we do give, but we restrict the volumes because it carries a lot of sodium as well.
Okay. So there's a question, apart from clinical parameters, what other non-invasive options we have to assess adequacy of fluid resource? And you mentioned POCUS, point of care ultrasound scanning. Is there any other measure of doing that?
Yeah. Basically, there are tissue level Dopplers. So a lot of new things are coming up in critical care, the tissue level Dopplers and other things. So pulse rate variabilities and other parameters. So there are a lot of, then we can do the passive leg bracing test to see their fluid response. So there are a lot of clinical and then instrumental parameters that we use to assess the fluid responsiveness and fluid adequacy.
And if all those things are not at your disposal in a very small hospital, I think we can always come back to resuscitation and with a fluid challenge and then see what the response is, isn't it? Okay. Then I have kept a question till the last moment because I thought that would be a good question, but we had to discuss on top of the other questions. So I'll come to that one now. When should we consider to introduce inotropes?
Very important question. Now, see, this obviously will fall into the resuscitation patient. So we basically, first thing that I need to tell is we need to fill the intravascular compartment before you start vasopressors. So we obviously know vasopressors are useful because sooner you get the mean arterial pressure back to the normal, better the outcome. So in extremely sick patients, we might start within the first hour of resuscitation after our second bolus or so. But if not, we would just assess the patient, reassess the patient and see whether the patient is responding to fluid bolus. And this can obviously be objectively seen with the point of care sonography as well. And if you are well filled only, you start some inotropes. That is also initially peripherally. And when the concentrations are quite high, you need to go for a central access. So the message, the answer is usually not at the beginning. Usually we need to fill up the intravascular compartment because there is definite sequestration of fluid into the interstitial phase. And once you are pretty sure you have filled up the intravascular volume and still the patient is hypotensive, then then there is a place for vasopressors.
Okay. And what would you use in various
It's
different
definitely noradrenaline through a peripheral line to start with, but obviously when the concentrations are high, you probably would need to go for a central access, either neck vein, peripheral neck vein, or a central CVP.
Right. So we have carefully avoided putting a central venous line so far. We have been relying on the clinical aspects of clinical evaluation and also non-invasive evaluations. But sometimes you might have a CVP line there already, or you might have to put it. So if we do put a CVP line, maybe it's already there in the ICU setting. In what way does that help in our management?
So this again, the opening pressure is important. So once if the opening pressure is low, then you can go for a fluid balance, fluid challenge, and then if the opening pressure is high, then you can either, if the opening pressure is low, less than 5, you give a fluid bolus, and if not, you give a fluid challenge and see what happens to CVP after a fluid challenge, whether the intravascular compartment can further accommodate fluid. So that is just to assess the patient's further response. If not, then you might need to embark on vasopressors and second line inotropes as well.
What would you like as a filling pressure?
Yeah, it's 10 to 12 of, depending on the patient. If the patient's got existing cardiac disease, it might be 15, 12 to 18 or so. So we tend to keep it around 10 to 12 of a CVP.
Okay. Okay, 10 to 12 centimeters of water. Yeah. We have covered all the questions that we have been typed into the chat box. And I think that was a very comprehensive coverage, which I hope that especially our frontline healthcare workers will find useful to, I'm sure, especially to improve their confidence. So basically, I think we can remember the 4 R's and the 5th one as well. That's very important. And also the important lesson that we can always have our initial plan and carry it out and then try to review in about 4 to 6 hours and decide what to do next. So no more questions. Yeah. Thank you very much, Prashant, for that wonderful coverage of intravenous fluids, the basics and beyond. I think that was a very useful session for all of us, myself included. And may I just, as a token of our appreciation from the college, present you this certificate of contribution.
Thank you, sir.
So ladies and gentlemen, that brings us to the end of this teaching capsule on Hall A on fluid management. So we will close this session now and please do join us again when the main session starts at 8:30 a.m. Thank you.